Okay, well, welcome everyone to tonight's webinar. Hopefully everyone's managed to join. I just wanted to give it a few minutes once we started the webinar, to make sure everyone's online and can see and hear me. So as you all know, tonight's webinar is about male fertility and infertility. And to put it in context, basically, I just wanted to let you all know what you need to know about your swimmers. So a little bit of background about myself. I'm Simon Kelly. I'm a fertility specialist at Fertility Associates in Auckland, and I've been with Fertility Associates for over 20 years now. An outline of tonight's talk, I wanted just to start off talking briefly about infertility in general, just to sort of set the scene. And then moving on to talking about the male reproductive system. I think that's really important for us to have an understanding of how the male reproductive system works, because then it helps us understand problems associated with male fertility and how we might treat those problems. So I'll take you back to secondary school and just give you a little bit of background to male reproductive physiology. So many of you will be aware that infertility is common, and this research, although quite old now, comes from New Zealand. And in New Zealand, around 1 in 4 couples will experience an issue with fertility at some point during their reproductive life. And the studies have estimated that around a quarter of women will have a fertility problem at some point, and around 1/5 of men will have a fertility problem. Infertility, for those who don't know the definition, it's essentially the failure to become pregnant after 1 year of unprotected intercourse, and that's generally a key marker that there may be some underlying fertility problems when that issue exists. We know that there can be a variety of different causes of infertility, and broadly speaking, around 40% may be male origin, 40% female origin, and then there's a 20% that can be unexplained or a combined male and female issue. And so really is important to understand the issues with male fertility, because they make up a reasonably significant cause of problems that we see for couples. So as I said, I wanted to just start off by talking about the male reproductive system. And as I said, I'm going to take you a little bit back to some basics here. And I just wanted to talk through this slide here, because I think it's really important just to have an understanding of how the male reproductive system works, because then it helps us understand later on when we're dealing with male fertility problems. So there are some key organs, obviously, in the reproductive system for both males and females. And it starts really with the brain. There's an area in the brain called the hypothalamus that produces particular hormones that control a very key gland called the pituitary gland, which sits at the base of the brain. Now, this gland produces some pretty important hormones, not only for male, but also for female reproduction. And these hormones, many people will have heard of, called FSH and LH. In the male, these hormones drive the production of sperm, or what we call spermatogenesis, and also lead to the testes producing the major male hormone, testosterone. And you'll see on the diagram here, testosterone has a role. It feeds back to the pituitary and the hypothalamus in the brain and regulates the production of these hormones from the pituitary. Just by way of comparison, these same hormones in the female drive the normal menstrual cycle, and they stimulate the ovaries to grow eggs and induce ovulation. And as a result of that, in the female, different hormones are produced, estrogen and progesterone. And these also feed back to the hypothalamus and the pituitary to regulate the female menstrual cycle. So you can sort of see that the key hormones are the same in both males and females. There are some major differences, however, and on the next slide, I will go through that. But essentially, just to sort of summarize, in the male, sperm is produced in the testes, and this is the process, as I mentioned, we call spermatogenesis, where immature sperm cells develop into mature cells, and it's under the control of these key hormones. And I want you to keep this sort of picture in mind, because when we get to some of the problems associated with male infertility, it'll help your understanding of those problems. These hormones can be affected by a number of things, and certainly, as you'll see when I talk about the lifestyle section, diet and exercise and avoiding harmful substances, may actually help maintain good, healthy male reproduction. Now, this slide here really just shows you the sort of major differences in how those hormones are produced, comparing females to males. So in the female, these hormones are produced in a cyclic fashion, which leads to regular menstrual cycles, and the levels of these hormones vary throughout the menstrual cycle. In the male, however, these hormones remain reasonably stable and static, and you lead to sort of continuous sperm production. So it's sort of estimated that in a woman during her reproductive life, she will produce around 400 to 500 mature eggs, whereas men over that time and throughout their lifetime produce billions of sperm. So sperm's continue to be produced, it's mass produced, and it can vary a lot in terms of how many sperm there are. So the number of sperm can vary immensely. And this sort of slightly complicated slide just shows you the point that because sperm is mass produced, sometimes there are times when the testes don't produce as much sperm as others. And this is basically a sperm count from a single man done regularly over the period of 2 years. And you can see how widely the sperm count varies. And in fact, on occasions, if you look below the yellow line, the sperm count is actually very low or abnormal. I think that's really important when you're assessing male fertility, just to understand that if you get a semen analysis or you get a sperm count that's very low, it may be that you're just checking it at a particular time when production is low. And that can be influenced by a number of things. So it's important not to make too much of a diagnosis on the basis of one sperm test, because sperm varies a lot. As sperm is mass produced, in reality, a lot of sperm is abnormal, or what we sometimes call junk sperm. And often the percentage of sperm that's actually normal in any sample is relatively small, but that's still just normal male reproduction. So what are the causes of male infertility? Well, I've sort of grouped them into different causes here, and I'll go through them one by one. So a reasonable percentage of significant male fertility problems are often genetic, but they can sometimes be due to developmental problems. They may be acquired due to sort of medical illnesses or exposure to different medicines or hormones. Chronic medical conditions can affect sperm production. There may be environmental factors that will affect sperm production, and there are some lifestyle issues which I'll go into in more detail. So we know that for genetic conditions, there are a variety of known genetic conditions that men inherit that can affect spermatogenesis and obviously their fertility. These can range from things we call aneuploidies, where men can have extra chromosomes or movements from one chromosome to another. Klinefelter's is a particular condition we see on occasions where men inherit an extra X chromosome, and that seems to particularly affect sperm production. Translocations are where one bit of a chromosome can migrate to another chromosome, and on occasions that can sometimes significantly affect a male's fertility. Cystic fibrosis, as many people will be aware, is a serious lung condition. And in order for someone to inherit cystic fibrosis, you would need to inherit a gene from both parents. But in our society and many other societies, the frequency of that gene is relatively common, and it's estimated that certainly in New Zealand, 1 in 30 people carry the cystic fibrosis gene. And in some men who carry the gene, they can, even though they don't have cystic fibrosis themselves, can be born with this particular condition where they don't have a vas deferens. Now, vas deferens is the tube that essentially transports sperm from the testes to the penis during ejaculation. The Y chromosome is critical for sperm production. It's what makes a male male. And on the Y chromosome, there are a number of specific genes that are really important for sperm production. And on occasions, you can get deletions of these genes, which will potentially significantly impact on that spermatogenesis. There are genetic conditions sometimes linked to the X chromosome, and there is a condition called Kalman syndrome, where men essentially have a non-functioning pituitary gland, so they don't produce that FSH and LH that I showed you in the original diagram, and so spermatogenesis doesn't occur naturally. And then there are a variety of inherited endocrine problems and specific gene defects that we know about that can affect male fertility. And often when we're evaluating for male fertility, we'll be looking to sort of look for these underlying genetic causes on occasions. There can be developmental or acquired conditions that can affect male fertility. Cryptorchidism, which is essentially a term that describes what we call undescended testes, is a situation where in men, the testes develop in the abdomen, but generally in fetal or early neonatal life, they migrate into the scrotum. But there can be varying degrees of failure of this, and often it's picked up in a newborn or in early childhood, and many men who've had this may have been told they had an operation to lower the testes into the scrotum itself. It's a procedure we call an orchidopexy. But there is an association between this and subsequently fertility problems later in life. I'll come to this a bit later, but the reason the testes are essentially outside the body is that they predominantly need a cooler temperature than core body temperature for normal spermatogenesis. So in anything that essentially can heat up the testes may in fact affect male fertility and spermatogenesis itself. Now, a varicocele is a dilated vein that can be on one or either side of the scrotum. They are relatively common, but when they are quite large, the increased blood flow associated with that can sometimes lead to an increase in the temperature of the testes and can affect fertility. So it can affect sperm production, sperm quality, and there is evidence that in some couples where there's a varicocele present, it may even affect the outcome of IVF treatment. If there's been an infection, that can certainly cause damage and obstruction, so inflammation or infection of the epididymis, which is the sort of storage part outside the testes. Mumps, particularly in early adolescence, is sometimes associated with orchitis or swollen testes, and again, there's an association with that and subsequent, sometimes fertility problems. More recently, we've certainly seen a number of men who've had an effect of spermatogenesis from having COVID. Many of you will remember during the peak of COVID, people talked a lot about spike proteins, and there does seem to be in many men a lot of spike proteins in their testes. So COVID is, the testes are a bit of a target organ, if you like, for COVID. And I've seen a number of guys, over the last few years where COVID has either significantly reduced their sperm production or in fact stopped it. It tends to be temporary and it does come back, but it can be a particular cause to think about. Guys may have had particular surgical procedures that might impact on their sperm production. Obviously, the classic one is a vasectomy, but many guys may have actually had the vasectomy reversed. And even then, there's not a guarantee that normal sperm numbers and quality will return. And some of these guys, even after reversal, can develop particular antibodies that can bind sperm, and these antibodies can prevent sperm from fertilizing eggs. So surgery in the groin region is potentially a risky procedure as well. I mentioned there's a number of medical issues that can affect sperm production. The most obvious one would be something like cancer treatment, particularly if it's chemotherapy or radiotherapy. Interestingly, any chronic medical condition may potentially affect spermatogenesis, and it's sort of believed that spermatogenesis is a little bit of a barometer of overall male health. So if male health is declined or affected by any condition, then you may see that represented in changes in spermatogenesis and fertility. There are a number of medications that potentially could affect spermatogenesis, and one of the ones that we're seeing increasingly is the use of androgens. So this is testosterone replacement. And you're certainly seeing a rise in the number of men using testosterone replacement for a variety of reasons. What's sort of a little sad is that many of these men and sometimes their partners are unaware that if you take testosterone, coming back to that diagram of the hypothalamic pituitary testis axis, testosterone will actually suppress production of FSH and LH, so it'll actually stop sperm production. And generally within 10 to 12 weeks of a male taking testosterone, sperm production will have stopped. The challenging thing is that even when you take the testosterone away, it can take up to 10 or 12 months before normal sperm production resumes. I've mentioned erectile dysfunction there because I think it's something that's not well talked about in the context of infertility, but it's something that is increasingly being recognised as an issue for many couples. And I think it's something that's not been researched particularly well, but certainly we are seeing in our practices that more and more men are reporting issues with erectile dysfunction, whether that's associated with stress. I think there's a variety of aspects to that. And I think often something that men don't tend to reveal very readily in consultations, and so it does take a little bit of work to sort of tease that out to see if it's a particular issue. Environmental exposure, particularly to some pesticides, heavy metals, and, as I mentioned, excessive heat exposure, again, might have significant impacts on spermatogenesis and male fertility. I wanted to expand a little bit on lifestyle factors because this is certainly something that I get asked about a lot in consultation. And I've sort of broken this down into a number of key areas, and I wanted to sort of elaborate on that. And I'll start off talking a little bit about smoking and drug use, and smoking is generally the big one that we know has an effect on both male and female fertility. I'll talk a little bit about diet and weight, and I'll talk about environmental exposure and our current understanding of what seems to be important there. I'm going to talk a little bit about stress. I will mention advanced maternal age. I think in general, when we're talking about fertility, we tend to focus a lot on maternal age, and certainly that is of prime importance, but there's no doubt that advanced maternal age, it does impact on male fertility and a couple's chances of conceiving. And I think that's certainly the case that we are seeing, more and more couples of not only advanced maternal age, but even advanced paternal age. I'll talk a little bit about supplements and just round off the lifestyle section with a discussion about frequency. So I know there's a lot of information on this slide here, but I did want to just talk through smoking and drug use. As I said, there's no doubt smoking is not good for any health, including fertility. We know cigarettes contain well over 7,000 harmful substances and are associated with impairment in sperm function. It's also associated with reduced success rates when it comes to fertility treatments such as IVF, and it seems to affect the number, movement, and the appearance of sperm. It also seems to cause an increase in damage to DNA, or what we call DNA fragmentation within the sperm. And this is probably due to the release of these, what are called reactive oxidative species, or basically chemicals that cause stress to cells and lead to cell damage, and smoking seems to increase the levels of these. Interestingly, in mothers who are smokers, there is an association based on studies with a high risk of birth defects and potentially some childhood cancers in their offspring. What we're not sure about, but it is of concern, is that whether that risk holds if their partner is a smoker, so therefore they're a passive smoker. So I think the data is of concern, that I think, even male partners to women who are pregnant should consider the potential that passive smoking might be harmful to their children. Alcohol, there's certainly evidence that a high intake of alcohol can interfere again with that hypothalamic pituitary testis axis, and it seems to be a progressively negative effect with increasing intake. What we don't know from the literature is whether there's a threshold above which alcohol becomes harmful, and of course that may be individual. There is certainly some evidence that alcohol intake is potentially an additive negative effect when combined with smoking. I get asked a lot about vaping. Unfortunately, there really aren't any human studies to date that have been particularly helpful, but there are some animal studies suggesting that vaping has a negative impact on reproductive health. So again, given the chemicals that are in vape mixtures, it's probably not too surprising. When it comes to other recreational drug use, marijuana has been studied for many years and has had a long association with lowered sperm counts or concentrations. I mentioned anabolic steroids or testosterone before, and as I said, based on the negative feedback that testosterone has at the level of the brain, the hypothalamus and the pituitary, it'll suppress spermatogenesis very quickly. Cocaine, again, both associated with short and long-term effects on spermatogenesis. Methamphetamine and MDMA or ecstasy, obviously more common in our community at the moment. Again, not a lot of human studies, but certainly some animal studies potentially showing an impact on that HPT axis as well. So none of the news is good when it comes to sort of recreational drugs. And when it comes to diet and weight, again, the studies here are are not overly conclusive, but I think there are a number of large studies, mainly what we would call observational studies, that do indicate that a healthy, balanced diet might improve semen quality and overall fecundity, which is just a term for fertility, essentially. And there is seemingly an association loosely with the Mediterranean-based diet and improved sperm parameters. And this is a diet that's rich in omega-3 fatty acid, antioxidants, vitamins, and typically it's associated with eating lean proteins, lots of fresh fruit and vegetables, olive oil, and sort of whole grains. And this compared to the sort of, in inverted commas, Western diet composed perhaps of more red meat, processed meats, refined grains, and energy drinks. Soy it contains quite a lot of estrogenic activity, and so if someone has a very high soy content to their diet, then there is the potential that it may affect sperm quality. I don't think that means you need to stop your daily soy latte, but I think it's just something to be aware of. There isn't really any clear evidence of a link between caffeine intake and male infertility. Although interestingly, there is some data suggesting that male fetuses exposed to high levels of in utero caffeine, so mothers who have a high intake of caffeine, may have subsequently reduced fertility in terms of semen volumes and lowered testosterone levels during their reproductive life. When it comes to weight, and in particular obesity, there's no doubt that obesity in men is associated with overall lowered reproductive potential. And with increasing body mass index, it's associated with reduced semen volume and sperm concentration or count. And men who are overweight or obese, they have more obviously adipose tissue, which is fat. Within adipose tissue, there are enzymes that convert hormones like testosterone to estrogen. And so in men who are overweight, potentially have higher levels of estrogen floating, again, potentially may affect that hypothalamic pituitary axis. Environmental exposure is something that's a little bit of a hot topic, I think, in fertility in general, but in particular when it comes to male fertility. In particular, we're concerned about the increasing exposure to what are called endocrine disruptor compounds, or EDCs. And these are a variety of chemicals, often from sort of plastics and a variety of man-made compounds, essentially, which essentially our concern is that they may affect the development of the testes in utero and may subsequently have a flow-on effect in terms of male fertility later in life. And these chemicals seem to have an effect particularly during fetal and early neonatal life. The concern about these drugs is that they seem to have a predominantly estrogenic effect. And so the concern really is that they may impact on normal reproductive development. There are also certain levels of pesticides which have been detected in breast milk and have been associated with an increased risk of this cryptorchism, or undescended testes, and hyperspadias, which is another congenital issue with the male, with the testes. Sorry, so that's cleaner come on the door. And overall, these chemicals have basically led to speculation that they may be responsible for the global decline in sperm quality and sperm numbers that's certainly been seen, over the last several decades. And I've just put that little graph there that sort of just demonstrates the sort of average drop in sperm concentrations that's sort of now well recognized. And it seems that it might be due to predominantly the increased levels of these EDCs in the water and perhaps our diet. And it does seem that the estrogenic effects of these compounds may actually be additive. We also know that certain heavy metals and hydrocarbons, so lead and cadmium, seem to be associated with low sperm mobility, motility, poor morphology or appearance of sperm. And so in particular, concerned about men who work in hydrocarbon industry, so petroleum industry, in particular, exposure to these chemicals might have some impact on their fertility. Again, coming back to heat exposure, I think there's no doubt that this can be a factor for some men. As I mentioned before, normal sperm production requires testicular temperature below body temperature, ideally between 34 and 35 degrees. So anything that essentially heats up the testes may create what we call this genital heat stress. That might be associated with guys who have relatively sedentary occupations, so, sitting for long periods of time, and taxi drivers, long-distance truck drivers, men who use spas or saunas at high temperatures for long periods of time. That, interestingly, does seem to be reversible. Again, coming back to guys who have varicoceles, the increased blood flow seems to heat up the testes and potentially lead to genital heat stress. And it may also be associated with some exercise activities, and certainly there's research showing that guys who where cycling is their main form of exercise, particularly if it's sort of for long periods of time, can lead to genital heat stress. I often get asked about cell phone use, and interestingly, there isn't a lot of great data on it. There's a few observational studies suggesting that prolonged use may impact on sperm parameters. It's not clear whether that's using the phone or having it in your pocket for long periods of time is the issue. But I think there's probably more information to come on that. Invariably, in a consultation, I get asked about stress and does it impact on fertility, both male and female. And to be honest, there's not a huge amount of data from the research, but there is some data that's quite interesting. As I said, in terms of male reproductive impact, there's pretty little conclusive data. There are some small studies that do show high levels of male stress might be associated with changes in hormonal production and subsequently lower sperm counts and motility or movement. One quite interesting study did show a relationship between occupational stress and poor sperm quality and increased DNA damage. But in the same study, it didn't show any relationship with life stress outside of occupational stress. And one quite cool study did, in fact, show that sperm quality on the day of their partner's egg collection when they were undergoing IVF was worse than previous samples. And it's thought that maybe this was due to the psychological stress of going through fertility treatment and perhaps their partner, going through a difficult procedure. You may be aware there's a lot of discussion nowadays about sleep disturbance and sleep hygiene and its impact on poor health overall. And there is some data to suggest that poor sleep hygiene might be associated with impaired male reproduction. And there's some studies from animal and human studies showing lower semen volumes and reduced sperm function in men who have poor sleep hygiene. And there's some added concern about the impact of electronic devices on our sleep hygiene and subsequently how that might impact on fertility. So I think anything that you can do to reduce stress is probably beneficial. So advanced paternal age, as I mentioned before, traditionally we've focused a lot on maternal age and its impact on fertility, and that's still very valid. But it's very clear now that advanced paternal age is associated potentially with reduced male fertility. And as a male ages, there is a general reduction in sperm concentration or sperm numbers, motility, and appearance does appear to be associated with an increased level of potential DNA damage in the sperm. And there are reduced pregnancy rates, not only with natural conceptions, but with fertility treatment with advanced paternal age. And there does appear to be an association with advanced paternal age and an increased risk of miscarriage in their partner. Just as an aside, there are quite well-established data now that suggests that advanced paternal age is also associated with an increased risk of certain inherited conditions, particularly the autism spectrum disorders and schizophrenia, especially in men over the age of 50. Supplements is another very popular topic that comes up in consultation. And unfortunately, it's an area that is very poorly studied, and evidence for the efficacy or effectiveness of many supplements is really just not there. And I often say to couples when I meet them that in the US alone, the fertility supplement industry is worth, I think, over $1.5 billion a year based on virtually no science. So it just shows you that you can sell anything to couples who are quite vulnerable and in a situation where they're looking for some help. There was one large study that looked at a number of specific male fertility supplements that are on the market and found that when they analysed the ingredients in all these supplements, only around 17% of the ingredients actually had any evidence whatsoever of potential benefit. And even that benefit for many was tenuous. I've just put a little list below of some of the supplements that probably have at least, the most amount of evidence to support some benefit, but even that is debatable. Zinc particularly does seem to be important for normal sperm development. So many men will take a zinc supplement. Vitamin C is a very strong antioxidant, and that might help improve spermatogenesis. CoQ10 or ubiquinol is an antioxidant that many people are taking, both males and females, for a variety of reasons, and there may be some link to improved sperm count, motility, and morphology as well. Carnitine is an amino acid that seems to be important for sperm motility in particular. And vitamin E is another very strong antioxidant that helps mop up these reactive oxygen species or free radicals that I talked about previously. But I think in general, for most men and probably for their partners, you're often best to focus on what you can change in terms of diet, maintaining a healthy weight. It's probably more effective than any supplement. Wanted to mention lastly, in terms of lifestyle issues, frequency. I often find that there's an assumption that if you abstain from ejaculation or intercourse for longer periods of time with the idea of building up more sperm, that may be helpful. Well, in reality, the opposite or converse is true. Frequent ejaculation seems to lead to more healthy sperm when you're trying to conceive, and longer periods of absence often lead to sort of more older and aged sperm, perhaps with higher levels of fragmented DNA. And in men, sometimes who have very low sperm counts, where we're trying to improve sperm quality, perhaps in the context of a fertility treatment, or perhaps we're trying to get enough sperm to freeze for a treatment, I'll often get them to go through a period of 7 to 10 days of frequent ejaculation before providing the sample. And sometimes the process of that increased frequency improves the sperm quality and numbers. So just to finish off with the lifestyle, the 4 sort of key tips I tend to sort of focus on are try and break those bad habits, in particular smoking or recreational drug use. Change the diet and eat healthily. Perhaps if you want to make a change, look at the Mediterranean diet. It does seem to have the most research behind it. Good exercise regime, trying to maintain a healthy body weight. And if you can, try and avoid stress. I know easier said than done, but there may be some benefit. So how do we evaluate male fertility problems? I've broken this section down into sort of 3 areas. I wanted to talk about the semen analysis, what examination might be looking for, and then some specialized testing. So semen analysis is the cornerstone of male testing, and often many men will have had a semen analysis before they come to see me for a consultation. Essentially, there are a number of parameters that we look at when we do a semen analysis, and there are very key rigid guidelines that are set by the World Health Organization, and these are reviewed regularly. But essentially, when we're doing a semen analysis, we are looking at the volume of semen on the semen. Is it viscosity, so how thick it is essentially. We obviously are looking at the sperm count or concentration, motility, or movement. We're looking at morphology, which is the appearance of sperm. And as I mentioned before, the majority of sperm in an ejaculate is often junk sperm, looks abnormal. And if you look at the bottom figure and those references there, if you've got 4% or more normal sperm, normal looking sperm, that's a normal semen analysis. There might be other factors that we look at, and I mentioned before, sometimes guys can develop these antibodies, particularly if they've had surgical procedures involving the testes. Sometimes we find other cells in the semen, cells that might be associated with infection or blood cells that might warrant further investigation. And this just little slide here just sort of shows you under a microscope what we're sort of looking at. So on the left-hand side is a sperm count. We want to see lots of nice normal moving sperm compared to the right-hand side of that where there's few sperm. On normal sperm, most people's idea it's got a head and a nice tail. Sometimes sperm look abnormal with shrunken heads, abnormal tails, and that just descriptively shows you that. And in terms of motility, what we want to see is a good percentage of sperm moving in a forward direction, what we call progressive motility. The physical examination, when in particular when we've based on the semen analysis got a fertility problem, we're obviously trying to figure out why, and so an examination is often the first thing that we will do, and that'll start with just a general examination, height and weight. We'll be looking to see that the male's developed normal secondary sexual characteristics, gone through adolescence and developed that. But it will largely be focused on examining the scrotum and the testes. So generally we're looking to see, is there any evidence that this man's had any surgery? As I said, sometimes surgery might have been as a neonate or young child and may not recollect much history about that. And this, goes to particularly things like undescended testes. Obviously want to check that there's normal penile and scrotal anatomy. We would generally feel for the presence of the vas deferens, which is, as I said, the tube that carries sperm. And feeling the epididymis, the storage area around the testes. We'd also check for these varicocele, so dilated veins. Many men who have varicocele will have probably recognized it themselves. But during the examination, to check properly, often what you need to do is have the man standing up and then perform what's called a Valsalva maneuver, which is essentially the same procedure when you're trying to clear your ears in a plane. And that often helps the varicoceles stand out so you can diagnose them. We obviously check the normal size and consistency of the testes and just feel for the presence of any masses. In my career, I've picked up, I think, 4 testicular cancers in guys who've presented with fertility problems. So it's something always to have a think about. As I said early on, that male fertility and particularly spermatogenesis may be a barometer of overall health. And so when a guy has an abnormal sperm test, you sort of need to think about, is there some other health issue that might be contributing to that? Then there's obviously some specialized testing that we might do. So that might start with hormone testing, checking those key hormones from the pituitary and the testes. So FSH, LH, and testosterone, that might give us a clue as to why there's a problem with the sperm. And as mentioned, we might do some specific genetic testing, perhaps a general karyotype, which is just checking the right number of chromosomes. Checking for cystic fibrosis, and looking sometimes specifically for deletions on the Y chromosome. We'll often, particularly in more severe cases, arrange an ultrasound to look at the testes, and they can also check for varicoceles and look for testicular masses. We might do a specific test to measure a male's level of DNA fragmentation. As I said, sometimes men have high levels of DNA fragmentation that may impact on their reproductive outcomes with their partner. And again, particularly if we're concerned about environmental exposure, that may be something we look at. We may also do a testicular biopsy to actually examine the tissue from the testes, although more often than not, that's in the context of trying to retrieve sperm in men who don't have any sperm in the ejaculate. It's what we call azoospermia. And there are some men where we are able to retrieve sperm from the testes and then use that sperm in the context of a fertility treatment with their partner. And there are a variety of causes for that, ranging from an obstructive reason, the sperm can't get out, or it may be due to the fact that the testicular is failing to produce or has significantly reduced its production of sperm. So when it comes to treatment for male infertility, there are sometimes hormone treatments that we might look at. Assisted reproduction is probably the most common thing that we look at now, and occasionally for some men, surgery might be appropriate. One thing I did want to just point out that often when we pick up particularly quite significant male factor problems, we would obviously do a series of tests to try and find out the potential underlying cause, primarily so we can hopefully get a diagnosis, but also look to see whether by getting that diagnosis, there may be something that we can help treat to improve the sperm numbers and quality. I think it is important to know that in many men, we don't get a clear diagnosis. And in that situation, often the only option is to look to things like assisted reproduction. But certainly hormone treatments to start with might be something that we would look at. And this would perhaps predominantly be in that group of men who have an issue with the hypothalamus, or in particular the pituitary gland, where they're not producing these hormones adequately. And so sometimes we can actually give back those hormones in the form of injections to restore spermatogenesis. Might be something we actually also do in men who have been on perhaps long-term testosterone use, where sometimes even though they take the testosterone away, we can try and speed up spermatogenesis by adding in these hormones to get spermatogenesis restarted. It tends to be less of something that's useful in men who have what we call testicular failure, where it's primarily a problem with sperm production within the testes. But occasionally there are situations where hormonal treatment might be useful. Now, assisted reproduction is really the sort of mainstay of treatment for mild and in particular severe male factor problems. The options really are to look at things like intrauterine insemination or IUI treatment, which is something that we would perhaps look at in situations where there's a mild male factor problem. Let's perhaps say the sperm count or motility, movement of sperm is a little reduced. This essentially involves either tracking their partner's normal menstrual cycle, sometimes with the addition of some medication to increase the number of eggs that she grows and releases, but predominantly looking for ovulation, and then at the time of ovulation, performing an insemination where a prepared sperm sample is placed effectively within the middle of the uterus in a minor procedure. And the idea here is essentially to get the sperm closer to where the eggs are at the time of ovulation. So basically giving the sperm a bit of a helping hand, if you like. You can't just inseminate with a full ejaculate volume from a male. So what we do is wash the sperm, and by doing that, essentially separates out the sperm from the seminal fluid. And before, if you looked at those sperm parameters, the average volume for an ejaculate is between 2 and 5 mils. But if you extract the sperm component, it's often down to sort of less than 0.5 mil. And that's the volume that we would inseminate at the time of the procedure itself. And then moving beyond that, there is IVF treatment. So in vitro fertilization, we would often use that for more severe male factor problems. This is a process where their partner would undergo what we call ovarian stimulation, so using medications to stimulate the ovaries to grow eggs. The eggs are then extracted from the ovaries when they're mature and then fertilized in the laboratory, which is in vitro fertilization, to create embryos. And subsequently, those embryos are cultured and an embryo is selected and then transferred into the uterus to try and achieve pregnancy. Now, traditional IVF involves, once the eggs have been collected, mixing a sample of prepared sperm with each egg and effectively allowing the sperm to bind and fertilize the egg naturally, albeit in the context of the laboratory. Now, in situations where sperm parameters, perhaps count, motility, or appearance is very, very low, even that may not work. So there is another technique we have called ICSI, which is essentially a sperm injection technique. ICSI actually stands for intracytoplasmic sperm injection. And basically, our scientists would pick up an individual sperm and inject it into the egg. And it really revolutionized the treatment of severe male factor infertility and was developed in the early 90s. So for many couples with significant male factor issues, this is often the treatment of choice and certainly would have the highest success rate. I mentioned surgery. There potentially are a number of surgical procedures that may be helpful. I mentioned the presence of varicocele, and often repairing or treating the varicocele will improve sperm parameters, but in particular may improve the outcomes for couples who are undergoing IVF treatment. Vasectomy reversal may be an option for men who've previously had a vasectomy, obviously, but in those situations, we would be weighing up the benefits of reversal versus another option perhaps would be to go straight to IVF treatment and use sperm retrieved surgically from the testes. Often when you're making that decision, the decision often comes down to their partner's fertility and which treatment was most likely going to give them the overall chance of success. Surgical sperm retrieval is a procedure I mentioned before where we actually retrieve sperm directly from the testes, and these are typically for men who have no sperm in the ejaculate or azoospermia. And as I said before, that can be either there's an obstructive reason why the sperm can't be found in the ejaculate, or potentially it's an issue with production of sperm within the testes or testicular failure. The amount of sperm we get when we do surgical sperm retrieval is tiny, and so it's only used in the context of couples doing IVF or in particular ICSI treatment. So surgery, yes, may have a role. So look, that's the end of my talk. I do have some time now if there are some questions. So hopefully you found that useful. I'm just having a wee look here at the questions that have come up. So one of the first questions here is, can certain clothing affect sperm quality or quantity? I think what alluding to here is the sort of boxers versus briefs sort of story. And I think it really comes down to this idea that if you heat up the testes, it may affect sperm quality. So not been that well studied, to be honest, but there may be some benefit in using boxers rather than briefs. Essentially, probably they heat up the testes to a lesser degree than briefs would. And so, yeah, there may be some benefit. I think it is a little debatable how effective that is if you already have a significant existing sperm problem, but there would be no harm in changing that to try and minimize this genital heat stress. So there's a question there about, do we do vasectomy reversals? Yes, we do. We do. One of our specialists here at Fertility Associates does do vasectomy reversals. It is a much more complicated operation than the vasectomy itself. So, like any operation, there are some risks associated with it, and with any operation, obviously the immediate risks are in terms of bleeding and infection, relatively low. I think the bigger issue with vasectomy reversal is the likelihood of it being successful. And there are a number of factors there. So the duration from the time of the original vasectomy to the reversal can be important, and it seems that the success rates drop off quite significantly if that's been more than 10 years. I think it also comes down to, what do you define as being successful after a reversal? I mean, in my mind, success is the couple end up with a baby. Whereas if you determine success, okay, you've done the reversal and there's sperm in the ejaculate, is that successful? In one sense it is, but doesn't necessarily mean that the sperm is normal. Of course, there's also this risk of anti-sperm antibodies I mentioned before. So even after a reversal, there will be a reasonable number of couples who may need more specific fertility treatment anyway. And so this is often a discussion when we're talking about reversal is, do you do the reversal, or do you look at the alternative option, which would generally be IVF treatment and getting some sperm directly from the testes? And as I said before, often that comes down to looking at female partner's age. So if you have a young female partner who's got time to conceive and you are happy to do the reversal, but if that's unsuccessful and then you need to move on to something like IVF treatment, you've still got time in terms of the partner's fertility. On the other hand, if female partner is older and has some issues with her own fertility, then you're more likely to be successful using IVF and surgical sperm retrieval. There's one question about bodybuilding, excessive exercise affects sperm. I think there's a lot of data about excessive exercise. I think in the bodybuilding, group, the main concern I have there is, not all, but many of those guys may be using androgen supplements or androgens, and that would be my main concern in terms of effect on sperm and sperm quality. I think anything that, as part of the exercise may heat up the testes, then okay, maybe there's going to be an effect there. But in the bodybuilding, group of guys that I've seen, the main concern there is around perhaps testosterone use, potentially at the current time, but potentially in the past as well. I think there's a similar question about hot tubs. I think the way I'd sort of look at hot tubs or saunas is, generally if you're using them for long periods of time on a regular basis, where those, the temperature of the hot tub or the sauna is, particularly the hot tubs, around body temperature or higher, there may be some effect in terms of genital heat stress. So yeah, I think I generally advise guys who present in the context of a couple struggling to conceive that if that's part of their lifestyle, there may be some benefit in restricting that use, or perhaps using a slightly lower temperature on the hot tub, maybe for not quite as long, and perhaps avoiding saunas, while you're trying to conceive. As I said before, it does seem to be something that's reversible. So if you stop using those things, if there was an effect on their sperm, usually it'll be reversible. So Not sure, just scrolling down here. There's one question here about improving sperm quality in males with a balanced translocation. So you remember early on I talked about genetic causes of infertility, and translocations, essentially where one bit of a chromosome moves to another. And in some guys, it can affect sperm quality. It really depends on which chromosomes are involved and probably which genes are involved in those chromosomes. If there is a sperm quality issue, it's probably related to the translocation. It would be debatable whether sort of lifestyle changes would make any difference to that, but I think it probably depends on the severity of the sperm issue to begin with. And some of these guys, often the sperm issues are quite severe, and okay, lifestyle things might still be useful, improving overall sperm quality, even if you do actually still need to end up having a fertility treatment such as IVF. So it doesn't discount the benefit of those things, but it may be less likely that you would be able to return sperm quality to normal. One specific question here about doing micro-TZ over a standard TZ. So what that question's talking about is surgical sperm retrieval, and there are a couple of techniques of obtaining sperm surgically from the testes. So a standard surgical sperm retrieval, or TZ, is a small open biopsy of the testes. We take a sample of testes, the scientists look at it under a microscope, try and find sperm, and then we freeze it, and then we use it in the context of an IVF treatment. Micro-TZ is a more advanced procedure or more involved procedure where it's done under an operating microscope, and the whole testes is essentially opened up. And you use the microscope to try and identify areas in the testes where sperm production may be more likely to be happening, essentially. And that compares to the simple procedure, which is a little bit of a blind procedure. You're just taking a biopsy. In particular, in guys who have testicular failure, where the testes have reduced the production of sperm, the micro-TZ has been shown in research to potentially improve the chances of obtaining sperm. And overall, often the chances of obtaining sperm, particularly if testicular failure is quite significant, can be relatively low anyway, but opting to do the micro-TZ may improve the chances of getting sperm. It is a much more significant operation, and the recovery is quite a lot more significant. So you're always weighing up that. In terms of costs too, if patients are paying for it themselves, it's a significantly more expensive operation. The micro-TZ under a microscope is done under general anesthetic and it can take over 2 hours to do. The simple biopsy can take 20 minutes and is done under local and a bit of sedation typically. Just seeing if there's any other questions there that I've missed. There is, I think the same question about micro-TZ there. Not sure if there's any other questions that people want to ask. Just give a few more minutes to see if someone's writing. Looks like that might be all the questions, guys. So maybe we'll wrap this up. I hope you found some value in that. Like any fertility topic, there's always so much more that you could talk about, and this has sort of hopefully just been a bit of an overview of male fertility. There are a lot more specifics to it in certain situations, but I think generally what I've described is sort of our current overview and understanding of the sort of key aspects of male fertility. So I think there aren't any more questions. We will wrap that up. Okay, look, thanks for joining, guys. Appreciate your attendance, and hopefully I look forward to the next webinar. Thank you.